You have two lectures on advanced life support or ALS, and this is the first one. I'm Saman, Dr. Samanna Nayakkar, Senior Lecturer in Anesthesiology attached to the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, University of Peradeniya. So in this lecture, you need to get familiar with three technical terms. One is cardiac arrest, second is basic life support, third is advanced life support. So we'll first see what cardiac arrest is. So what is a cardiac arrest? So a cardiac arrest means basically is one's heart has stopped. Cardiac arrest, as the word implies. The heart has stopped, therefore ejection, pumping of blood has stopped. There's no cardiac output, there's no blood pressure, hence there's no peripheral perfusion. So all organs and systems are going to suffer because there's no perfusion. So the brain is not being perfused, the heart is not being perfused, the muscles are not being perfused. So basically, the body has come to a standstill and the man is going to die. So how can you recognize a cardiac arrest? So if you can remember, a cardiac arrest is where a situation has arisen where there's no response by a person and there's no breathing and there's no pulse. That's basically enough. And there's another slight deviation from this definition. That definition came up because world authorities of cardiac arrest management, life support, tried to uh, train lay people also for recognition of a cardiac arrest and then to start bystander cardiopulmonary resuscitation. So, what do you mean by bystander cardiopulmonary resuscitation? Bystander CPR or bystander cardiopulmonary resuscitation is what is expected by whoever who is by the side of a victim who sustains a cardiac arrest to start CPR or cardiopulmonary resuscitation. So, if the person who is nearby the victim who suffers a cardiac arrest is a lay person, not a medical person, not a healthcare worker, uh, out of the three things that I mentioned earlier, lack of response, absence of breathing, and absence of pulse, it generally is difficult for a non medical person, a lay person, to look for pulse. So, checking for pulse was removed from the definition of a cardiac arrest uh, to make it suitable for lay people. Therefore, finally, the definition came as absence of responsiveness and absence of normal breathing in a person. Well, this is a bit of a tricky definition. So this person is not responding, not breathing, but we call it a cardiac arrest, and pulse may have stopped or may not have stopped. But all of us know if somebody has stopped breathing, there's no oxygen going into him, the heart may be working for another few seconds to 1 minute, and very soon the heart is going to stop. So, for all practical purposes, this definition is correct because the heart is going to stop anyway within a few seconds and then there's no pulse. So, that is also true. Well, if medical people can recognize a person soon after stopping breathing, before the heart also stops, then we call it a respiratory arrest, and a cardiac arrest has not yet happened. So that can be done only by medical staff, and especially if the patient is in a hospital setting, especially if the patient is being monitored. So we can easily recognize the fact that patient is unconscious and not responding and there's no breathing, but still there may be a pulse. Then we call it a respiratory arrest, and very soon there's going to be a cardiac arrest also. Then we call it a cardiopulmonary arrest. So there are many terms like this, and you have to know how these terms are being used interchangeably by lay people and medical people also. But for an exam purpose, if you say, if you asked about a cardiac arrest, what a cardiac arrest is, if you just say cardiac arrest is absence of responsiveness of a person, absence of breathing, that is also correct. But since we are medical people, when we are checking for presence or absence of breathing, we can always keep our hand on the neck of the victim and check for carotid pulse. And within 10 seconds, we can verify whether there's pulse or not. So for us, it's not a big deal. While checking for presence or absence of respiration, we can also check for presence or absence of pulse. So I think for our purpose, the cardiac arrest is absence of responsiveness, absence of breathing, and absence of pulse. And there are many other things that you might hear sometimes, different people saying, please don't take those into your mind. For instance, to recognize a cardiac arrest, you don't have to check for pupillary signs. It's not necessary. You don't have to listen to heart sounds. You don't have to measure the blood pressure. So, blood pressure, heart sounds, pupillary signs, all have been removed. Well, for those who are never in the definition, you don't have to look for those things to recognize a cardiac arrest. Right. So, why are we learning about CPR or cardiopulmonary resuscitation or life support? Because if somebody has sustained a cardiac arrest, the heart has basically stopped pumping blood. There's no perfusion to the brain and all other organs because there's no cardiac output, hence there's no blood pressure. So, out of all organs, brain is very susceptible to hypoxia, hypoxic injury or ischemic injury. So, the brain is going to sustain permanent brain injury, permanent hypoxic injury if the brain does not get oxygen within 3 to 4 minutes. So, it is very important that doctors and the medical staff recognize a cardiac arrest very early and get going with cardiopulmonary resuscitation, which is part of advanced life support. So there's no time to learn about cardiac arrest management if a cardiac arrest has happened now. There's no time to refer to textbooks. There's no time to consult your senior doctors or your consultant. So whoever who is present by the side of the patient has to perform life support at the site. That is very important. So you may be the junior most doctor in the ward, or you may be the dental student in the ward, or the medical student in the ward, and a cardiac arrest has happened. Whether the patient is going to survive or not will be dependent on what you initiate and what you start, and whether you can do an effective life support. Your on-call consultant may be at home, maybe in another place in the university or in the hospital. He may be a professor, but those things are not relevant for the survival of the patient. What is important is whether the doctor who is in the ward can start a proper resuscitation. Now look at these two pictures. You can see in this picture which I am showing on to your left. So this probably is a battlefield where one person has collapsed and two of his colleagues are trying to resuscitate him. So this is what we mean by basic life support. So the other term we are using in this lecture. And on the other photograph on to your left, you can see another victim of a cardiac arrest. So he has collapsed, and the person who is trying to resuscitate him either must be a policeman or a security officer. He has brought an automated defibrillator and has attached the pads of the automated defibrillator to the victim, and he is trying to perform chest compressions. So you can see him keeping his hands on the middle of the chest. So, well, this automated defibrillator will prompt him as to what to do, whether to deliver shocks or to start CPR or things like that. Now, so this is basic life support. Well, one difference between an ordinary basic life support and this basic life support is he has an automated defibrillator here which will recognize the rhythm of the cardiac arrest and which will prompt him as to what to do. So this is a bit of an advanced thing we are talking about. Anyway, in basic life support, there may or may not be many people to help. Only one resuscitator may be there, maybe there are two resuscitators. Generally there are no drugs available, there are no equipment available. So this is a special situation, although these two are special situations. Although basic life support is going on here, there seem to be these people who are trying to handle the basic life support have some training for these things. So they may be having some equipment. You can see this person is wearing a stethoscope, and he may be carrying some drugs here. So these may be paramedical staff uh, helping the fighting troops in a battlefield. So when somebody collapses, they call these paramedical staff. They are nearby or a little far away, but they are called for an emergency and they come and start resuscitation. Right. So why should we learn life support? By learning life support, all of us finally have learned a standardized approach to cardiopulmonary resuscitation. And in case of a cardiac arrest, all are practicing the same protocol. And we have a trained set of people or staff. We have equipment ready, available at hand. Therefore, there's better handling of a crisis. Well, cardiac arrest is a crisis. That's a medical emergency, and that is the worst medical emergency you can ever have. And there's no medical emergency more serious than that. Now, this victim who has a cardiac arrest is going to die, and you need to act very fast. Even if he doesn't die, his brain is going to die if you do not provide oxygen within a couple of minutes. A maximum the brain is going to sustain is 3 or 4 minutes without oxygen. Thereafter, the brain is going to sustain permanent hypoxic injury. So it is worse than even dying. What if a patient survives? If a patient is living and if the brain is not working, so he would be a vegetable on the bed. Others have to do everything of him, including removing feces and urine. He cannot talk, he would not recognize others, he doesn't know what's happening. Others have to feed him, wash him, look after him, do everything if his brain is dead. Right. Right. When we are talking about the survival of a victim who has had a cardiac arrest, we are talking of a chain of survival. Now, there are several points in this chain. So, it's looking like a chain exactly. So, there are four main links. So, the first link is early recognition of the cardiac arrest and call him for help. So, we learned why should we recognize it early, because the brain is going to sustain permanent brain injury if resuscitation is not started immediately. So the next link is early CPR, early cardiopulmonary resuscitation by the bystanders. Third is early defibrillation. So you will be learning about defibrillation within this lecture and the next lecture. Next is early advanced life support and post resuscitation care. So we will be learning these things in the time to come. Okay, a few more examples of basic life support and advanced life support. Now, I'm showing these slides with an idea of showing some modifications that we have adopted with the COVID concerns. So now, forget about COVID for a moment. Now, so this is an example of providing basic life support. So this girl is in a swimsuit, and this is by the side of a swimming pool. This person is in a uniform, seems to be a recognized resuscitator. So this girl or lady would have got drowned here and has sustained cardiac arrest. So this person has come to uh, resuscitate the girl or lady, and you can see he's wearing gloves. So obviously he had been ready for that, and he's keeping a pocket mask on the victim's mouth. So this is the box or the case in which the pocket mask is kept. So you open this box, take the pocket mask out, keep the mask on the victim's mouth, and there's a small tube, and at the end of the tube he can keep his mouth and blow. If you look at this drawing, you can also see a person. He's not in a uniform or not in a sort of a cloth that you wear when you leave home. So he would have been inside his home or inside a workplace or wherever. You can see this person is resuscitating an adult, whereas this person is resuscitating a child. So in the lower picture, he's giving mouth to mouth breaths to a child, and in this one you can see again the resuscitator, rescuer, giving mouth to mouth breaths to this adult, and here you can see giving chest compressions to this adult. Now, because of COVID concerns, some of these practices have gone out of practice. Now, we do not give mouth to mouth breaths because we are not sure. We do not recommend mouth to mouth breathing or mouth to nose breathing because we are not sure whether this victim has COVID. In which case, there's a chance for the resuscitator, rescuer also to catch COVID. Therefore, mouth to mouth breathing and mouth to nose breathing are no longer recommended. Even trying breaths with a pocket mask is now no longer recommended because still the rescuer or the resuscitator has to come very close to the victim's nose and mouth, and that's not safe for the rescuer. So, what is now recommended is chest compression only resuscitation, where the victim can do chest compressions, and if well this victim is not a known person, it is advisable to cover the head area, nose and mouth with a cellophane or color. Well, we do not know whether it will be possible to find a cellophane in a situation like this. That's a different story. Anyway, minimal handling and touching and contamination of yourself with patient's nasal and oral secretions. This is something you have to remember. So, basic life support versus advanced life support. So, this seems to be a medical person, a doctor wearing a uniform, wearing gloves, equipped seems to be inside the hospital. There's a team, there are medical equipment. You can see this doctor is intubating the person, passing an endotracheal tube or a breathing tube with the help of a laryngoscope. So, this is a laryngoscope, this is the handle of the laryngoscope, this is the blade which has been pushed into the mouth. So there's a light at the end of it, and using that she can see the opening laryngeal orifice and pass the endotracheal tube through the laryngeal orifice into the trachea, and then connect to an ambu bag or a ventilator and start resuscitation. So this is a team inside the hospital doing resuscitation. So one several basic differences between basic life support and advanced life support. When it comes to basic life support, the rescuer, the resuscitator may be alone. If he or she is lucky, there can be one or two resuscitators or rescuers like the previous photo, photograph we saw. And in advanced life support, which is performed inside the hospital, generally there are several people and no special equipment here. Well, of course, except for in this situation where this rescuer was ready and he is officially designated for this purpose. If this happened by the side of a river, not inside a pool of a big hotel or anything like that, there wouldn't be rescuers and there wouldn't be anybody wearing gloves and there wouldn't be anybody ready with a pocket mask. A bystander just passing by, or another person who has come to swim or dive would take this victim out and start resuscitating. And whereas in advanced life support, there are equipment available, and there are no medicines available in basic life support, and there are equipment medicines available. So adrenaline and amiodarone will be available here in advanced life support. Right, so again, why should we learn life support? Because whoever who is there has to do resuscitation. Now look at this photograph again. So there's a victim who has collapsed and there's a set of medical staff. One person is doing chest compressions, one person is trying to do ambu ventilation, one person is trying to cannulate. Well, they are wearing gloves, so we can see some medical equipment. There's a team. So this is uh, advanced life support. And on this side you can see a photograph where basic life support is being supported. So these two may have gone on swimming or diving, and one person has collapsed or let's say got drowned, and the other person is trying to help by resuscitation. So only he seems to be there. We can't see any other people, we can't see medical equipment, we can't see drugs. So in basic life support, we maintain airway, support breathing and circulation without the support of equipment and special medications, generally other than protective devices. Even protective devices may not be available when it comes to basic life support. Okay, right now look at this algorithm for adult basic life support. So now, so this is the algorithm from the Resuscitation Council of United Kingdom. So this is what we generally follow. So if you see a victim, just check for responsiveness, and if he's not responding, call for help, shout to help. And now you need to check for breathing. Before checking for breathing, you have to open the airway, because if the airway is closed, if there's airway obstruction, even if the patient is breathing, you cannot detect breathing. So therefore it is very important to open the airway. How do you open the airway? By head tilt and chin lift. And if you are suspecting a possibility, if you are suspecting a cervical spinal injury, then do not do head tilt and chin lift, just do jaw thrust. You will be learning these things in practical sessions, which we will be doing in the operating theatre and the intensive care unit. Don't worry. And open the airway and then check for breathing. Now, I'm intentionally showing the older version of resuscitation algorithm to because I want to strike these basics and I want to drive them into your mind. Some of these things have been changed due to COVID concerns. So now, when it comes to checking for breathing, we do not try to listen for breath sounds and we do not try to feel for breath sounds, but we only look at the chest of a person to see whether the person is breathing. So you can do it while staying 3 feet away from the person's mouth and the nose. And if there's no breathing, what does that mean? It means this is a cardiac arrest. So let's say the person is not responding, not breathing. So for all practical purposes, this is a cardiac arrest. Now this call 999 is what is applicable to United Kingdom. So in our setup, we can call 1990 1990 and call an ambulance to come to where you are. And you, but meanwhile you are starting resuscitation. How do you start? You are starting chest compressions. You are straight away going to deliver 30 chest compressions, and at the end of that you are going to give 2 rescue breaths. Now again, this is the older algorithm. Now, rescue breaths have again been taken out of the algorithm due to COVID concerns. Well, if this is a victim who is inside the hospital, and if you know that the patient is PCR negative or rapid antigen test negative for COVID, and if you are wearing personal protective equipment like PPE, you can take care of yourself. Then you can give 2 rescue breaths with even a face mask. If you are a trained medical person, you can do it with minimal generation of aerosols. Now again, this is the algorithm of the Resuscitation Council. Right now, let's go through the sequence. Oh, things in an order from the beginning. Let's say you are seeing a person who seems to be unconscious. So what is the first thing to do? First, see whether it's safe to approach the victim. Right, so first you have to look after yourself. So, and you are the rescuer here, you are the resuscitator here, and if you fall into trouble, the victim is going to die anyway, and you will also, you may also harm your life also. So what do we mean by seeing whether it is safe to approach? So see whether there may be a poisonous gas being emitted, a toxic gas, fume, and if you go there without looking around, you will also fall into trouble. There may be a snake. A snake may have bitten this person. Oh, there may be things falling from a height, and you go and start resuscitating the person there, and the next thing will fall onto your head. Let's say these things falling apart from a wall or from a roof. So, the person may have got electrocuted. See whether there's a pool of water or something, and whether the person is in contact with a live wire. And so, in which case, first you have to go and switch off lights and remove the wire. Then only you should approach the victim. So first thing is to see whether it is safe to approach. If so, you are approaching. Check for responsiveness. So how do you check for responsiveness? Just talk to the person, ask what his name is. Ask, you can ask him or her why he's lying like this on the ground or floor, to tell his name or something. You can just shake the shoulders, tap on shoulders, and see whether he's going to respond. Let's say he's not responding. Now, next thing is to check for breathing. So, as I mentioned earlier, before checking for breathing, you have to open the airway. So, how do you open the airway? By head tilt and chin lift. So, keep one hand on the forehead and do a head tilt. Keep the other hand on the chin and do a head tilt and chin lift. But if you are strongly suspecting a cervical spinal injury, if there's a possibility of a cervical spinal injury, like in a person who has been thrown off from a three-wheeler or motorcycle, or somebody who has fallen from a height, there's always a possibility of cervical spinal injury, in which case you do not do head tilt and chin lift, but you are doing jaw thrust. Get hold of the angle of the jaw, angle of the mandible, and just apply some pressure upwards. So you have opened the airway. Now you are going to check for breathing. So we do not recommend checking for pulse by lay people, but medical staff can check for pulse at the same time that you are checking for breathing. So now, the previous method of checking for breathing was looking for breaths, listening for breath sounds, and feeling for breath sounds. So you bring your cheek and ears close to the victim's mouth and nose, and you are trying to listen for breath sounds. You are going to feel for his breath falling onto your cheek, and at the same time you are looking at the chest of the victim to see whether the chest is going up and down. But as I mentioned earlier, we have stopped doing listening and feeling due to COVID concerns. We can look at the chest to see whether the chest is moving up and down, and at the same time we can check for pulse by keeping our hand on carotid artery, just on the side of the trachea, just next to trachea. So you can easily see the trachea of anybody, and keep your fingers on the trachea and slide it to a side. Then you will get the carotid. If there's no carotid pulse, don't waste time on checking for other pulses. So there's no point in checking for other pulses. If there's a pulse, carotid pulse has to be present. It is one of the most prominent pulses in the body. So if it is not present, other pulses are also not there. So if there's no response and no breathing and no pulse, this is a cardiac arrest. You have to start resuscitation immediately. Right. So a laryngeal mask or LMA is something in between a face mask and an endotracheal tube. So this is an alternative way of establishing a reasonably definitive airway. Now, to do intubation, you need skills. You need to have trained. You need to have got trained for intubation, how to do laryngoscopy and how to do intubation. So, for a person who is not trained in doing endotracheal intubation, can pass a laryngeal mask airway LMA. You will be learning these things in the operating theatre and the intensive care unit. Right now, this is the older way of uh, checking for breathing. So you can see this lady is listening to the breath sounds and trying to feel for breaths on on her face, and at the same time looking for movements of the chest. So look, listen, feel, and a medical person can keep this hand or this hand on the neck to check for pulse at the same time. So here this gentleman has done head tilt and chin lift and has brought his face close to the victim's nose and the mouth to feel for breaths. Well, this is a little too high. You have to, if you are to feel for breaths, you have to bring your face a little closer. But now we are not going to do listening and feeling, but only look at the chest with cautions due to COVID. Right, so this is what we taught earlier and what we learned as medical students. We learned how to do mouth to mouth breaths. So this is now totally out of practice. You can do it only for your close family member, again, in whom also, if you are sure that this person hasn't got COVID. Then comes the question of how can you be 100% sure that even this family member of yours has no COVID. Now, so mouth to mouth breathing, mouth to nose breathing are not done. So when it was done, this is how it was done. So the victim is like that. So the rescuer has to come and do head tilt and chin lift, open the head, close the nostrils, open the mouth like that, and deliver artificial breath. So with two rescue breaths, so open the airway, pinch the nostrils, take a deep breath, tight seal around the victim's mouth, and deliver a breath. So this may still have a place if this person is your child, your own child. Then well, you will not be considering COVID. It is if it is your child, you can still do a mouth to mouth breath. So there are a few occasions you can still think of this having a place. So that's why I have put it here. Right. So this is how you deliver breaths. So mouth to mouth breathing is gone totally out of practice. So this is how you deliver breaths through a face mask using an ambu bag. So this is an ambu bag. This is a face mask. Now, if this is a patient, you have to wear gloves. Not wearing gloves is not at all recommended on a patient. So now these were done like this without gloves when there was no concern about COVID. So this is how you keep a face mask. Face mask is a sort of a triangular thing. Keep the triangular apical part over the nose, base of the mask around the chin. Right, so you are trying to establish airway further. So this is another photograph of direct laryngoscopy and intubation. So this is called direct laryngoscopy because you are looking at the larynx directly. So using a laryngoscope, like in the previous photograph, you can remember. So this is a photograph of again doing laryngoscopy. This is the laryngoscope handle. Blade is like that inside the mouth, going up to the throat, going up to the vocal cords, and the endotracheal tube is being pushed through the vocal cords. So this person is wearing gloves and a mask. And so now with COVID concerns, again, you should be wearing a cloth up to here. So you should not have bare areas of your body like this. You should be wearing a dress with long sleeves, and the glove should be over the long sleeves so that even these parts are covered, and better to wear a visor. So you are protecting your eyes, nose, and mouth. On top of the mask, you should wear a visor. And here's a situation where chest compressions are being done while bag and mask, sorry, ventilation is done through the endotracheal tube. So now intubation has been done. So now the endotracheal tube, the tip of each is connected to the ambu bag. Thereafter, chest compressions and ambu ventilation can be done. Write a few more words about delivering. So right now, what are the COVID concerns and the modifications done due to COVID concerns? So we have come to the last slide of the lecture. So we have to wear PPE, personal protective gear. So we have to wear a gown with long sleeves, wear gloves, wear a mask and a visor. And no need to do listening and feeling for breath sounds. For a loved one, you can cover the face of your loved one with a cellophane and do chest compressions only, CPR. If this is an unknown person, you can wear PPE. Do not do any aerosol generation procedures. And so if this is an unknown person, If you have no PPE, wait till PPE is brought to you. Till then you can clean the area till help comes with this. Let's say if the person has fallen and there's there are chairs and other furniture around, maybe you can push those things to a side and create some room, and then pass an IV cannula drip. You can do defibrillation. So cannulation and starting a drip and defibrillation are recommended even for an unknown person, because you are not generating aerosols here. Now, if you are wearing personal protective equipment PPE, you can still do suctioning of the airway. Well, minimal airway suctioning can do mask ventilation also by a trained person, not an untrained person. Well, try to do minimal mask ventilation. Even if you are wearing PPE, you can pass a laryngeal mask airway. Even with laryngeal mask airway, chest compressions to ventilation, best still better to restrict it to 30 is to 2. Earlier I mentioned you can do 30 compressions and 12 breaths, but here with the laryngeal mask airway there's still a possibility of generating aerosols, so you continue compressions and ventilation at a ratio of 30 is to 2, not 30 is to 12. That is with an idea of minimizing aerosol generation. So early intubation and connect a viral filter to the endotracheal tube, to the proximal end of the endotracheal tube. Therefore, you are protecting yourself, others around, and the ambu bag and everything else you are going to use by not allowing, if there's a possibility of a COVID infection in this person, not allowing the COVID virus to enter the ambu bag and other tubings. So this is the end of that lecture, and in the next lecture, advanced life support 2, you will be learning about supporting circulation. So in this lecture we learnt about the approach to a victim who has a cardiac arrest. We learned that we have to look around and make sure it is safe. Then we learned how to open the airway, and before that how to check for responsiveness, then to open the airway, then to check for breathing, and at the same time to check for pulse, and to start chest compressions and breaths. So in the next lecture we will be largely concentrating on delivering chest compressions and defibrillation and delivering drugs. So we'll stop there.